Hi, I'm Judy Alonzi, and I'm a developmental specialist in early intervention, and I'm also a teacher of the deaf and hard of hearing. I currently work in Chesterfield County Infant Program, but my experience working with deaf children throughout my career includes working at a school for the deaf, as an interpreter, as a resource teacher, and as an itinerant teacher. Our training today is Services for Children who are Deaf of Hard of Hearing in Early Intervention. My hope is that this training serves to provide some basic information about the early identification process, the confirmation of hearing loss, the referral process to early intervention, the different modes of communication, and entry into early intervention. After that foundation of information, we will then talk about some of the approaches, strategies, resources, and materials that all service providers with an interest in serving children identified with a hearing loss can access and help families and children at the beginning of their journey. To best serve children in early intervention with a hearing loss, I believe there are several best practices that should be followed. And I hope that these practices serve as the learner outcomes for this training. First, an early and confirmed diagnosis of hearing loss. Next, a timely referral to early intervention, intake process, and the assessment for service planning, or ASP. The Individualized Family Service Plan, or IFSP, is written with the family that captures their goals and outcomes for their child. The family is then matched with a competent service provider in early intervention in their communication and language choice. And lastly, we want to assist families with resources and coaching within the child's natural environment. So let's start with the Virginia Early Hearing Detection and Intervention legislative mandate that is in place. We are now identifying children with hearing loss shortly after birth. And after follow-up with an audiologist, these children are now coming to early intervention for services at a very young age. So how many children are we talking about? According to the American Academy of Pediatrics, hearing loss occurs at approximately 1 to 3 infants per 1,000, and those children are identified with moderate, severe, or profound hearing loss. Hearing loss is even more common in infants admitted to intensive care units at birth. If hearing loss is not detected and treated early, it can impede speech, language, and cognitive development. Prior to the newborn hearing screening, children were on average identified with a hearing loss when speech did not develop on time. Sometimes that timetable could mean the child was 2 or 2.5 when identified in many cases. A little background on how we got here to early identification. In 1993, the National Institute of Health held a consensus development conference that endorsed the screening of all newborns for hearing loss before the child leaves the hospital. Then in 1997, a National Institute of Health panel recommended standard screening methods for use in nationwide newborn hearing screening programs, methods still used today. As a result of this recommendation, a state-by-state effort was initiated to promote the mandatory screening of newborns. Helping this effort was Congress's passage of the Newborn and Infant Hearing Screening and Intervention Act of 1999. Which helps in the coordination and funding of statewide programs. Virginia Early Hearing Detection and Intervention was put in place, which we refer to as EHDI. The Commonwealth of Virginia adopted the legislative mandate that requires all hospitals with newborn nurseries and/or neonatal intensive care services screen the hearing of all newborns prior to discharge. This information is reported to the Virginia Department of Health through the Virginia Infant Screening Infant Tracking System, what we call VISITS, and in the Virginia Vital Events and Screening Tracking System. It is the goal of the VISITS system that children that are identified at birth as having not passed their newborn hearing screen are not lost to follow-up once they are discharged. To summarize the mission and intent of the Virginia Early Hearing Detection and Intervention Program, or EHDI, their mission is to minimize or eliminate communication disorders resulting from hearing loss, with the goals of identifying congenital hearing loss in children before 3 months of age and then assuring enrollment in appropriate early intervention services before 6 months of age. So what are the recommended guidelines for the process into services? After the universal newborn screening mandates were put in place, it was suggested something be done to make sure babies identified at birth made it into services by the Healthy People Initiative meeting. A Joint Commission on Infant Hearing in 2000 did a position statement on newborn hearing for the 136 plan, and it was then adopted by EHDI nationally. It states that hearing screening should be done before 1 month of age, hearing evaluation before 3 months of age, and then enrolled in early intervention before 6 months of age. So how are we able to assure children make it from not passing their newborn hearing screening in the hospital all the way to early intervention services? Back to that Virginia Infant Screening Infant Tracking System, or visits. All hospitals in Virginia enter results of the newborn hearing screening into visits for all babies born in Virginia. EHDI is notified of children that did not pass their hearing screening, and a letter is generated to the family to follow up with an audiologist. Many times a phone call is made as well. A list of local pediatric audiologists is provided to families by EHDI and sometimes from the hospital at discharge. The family is also given information on EHDI PALS. EHDI PALS is Early Hearing Detection and Intervention, Pediatric Audiology Links to Services. This is a web-based link to information, resources, and services for children with hearing loss. At the heart of EHDI PALS is a national web-based directory of facilities that offer pediatric audiology services to young children who are younger than 5 years of age. This site also contains great web resources for parents and professionals. After the family has left the hospital with the results the child did not pass their newborn hearing screen, the next step is to schedule now with one of the identified pediatric audiologists in their area. An ABR, or auditory brainstem response hearing test during sleep, is the preferred method for follow-up testing. When the state of Virginia adopted the early hearing detection and intervention mandates, they decided that any audiology center that has the equipment for an ABR, which is that auditory brainstem response, or an OAE, and that is an otoacoustic emissions test, be available to do follow-up testing for a child that did not pass their universal newborn hearing screen. The state wanted to make sure it was easy for all babies in getting to an audiologist and reduce the chance of loss to follow-up. The reason an ABR is preferred is an OAE may not be as accurate or sensitive and may miss hearing loss as a false negative as possible, or when a child presents with auditory neuropathy. Children over 6 months of age may require a sedated ABR. Then, most importantly, the follow-up pediatric audiologists enter their diagnostic results that equate to a permanent hearing loss in 2 visits, that tracking system. When a hearing loss is confirmed, the audiologist will then recommend amplification based on the type of hearing loss the child presents with. A hearing aid is making use of a child's residual hearing and amplifying the sound in his or her environment. The 2 hearing aids on the top of the slide, one with the ear mold attached, is for children with hearing loss up to the moderate and possibly the moderate to severe range. When fitted with hearing aids, the child with that degree of loss should have access to all of the sounds necessary to develop spoken language. In the center are 2 cochlear implants. Cochlear implants, or CIs, have an internal surgically implanted device that, in conjunction with the processor and transmitting coil pictured here, stimulate electrodes within the inner ear in the cochlea. This allows receptor cells within the cochlea to pick up the signal directly and send the signal to the brain to be interpreted. Children who would be eligible to receive a cochlear implant present with a severe or profound hearing loss. For children where the hearing loss falls in the outer or middle ear, such as microtia and atresia, they may benefit from a BAHA. Here the BAHA, or bone anchored device, is pictured on a soft band. A bone anchored device can be surgically attached, but that is usually after the age of 8. So how do we get our referrals in early intervention? Back to that visits, that tracking system. All 40 infant and toddler agencies in Virginia use visits. Typically, the intake coordinator is the point of contact for that tracking system in each office. The intake coordinator will receive an email from visits about a referral for a child with a hearing loss in their locality. They log into the visit system to access the hearing loss and family contact information. Additionally, the intake coordinator may also receive referrals for children with diagnosed hearing loss from the parents, NICUs, EHDI, audiologists, and pediatricians directly. The intake coordinator then contacts the family to see if they are interested in early intervention services and to set up an intake. So now it's time for the intake visit. Backing up to that intake phone call, families are requested at that time to bring in audiological reports to the intake meeting if possible. When the family has the intake meeting in the infant program office or in the home, in addition to all of the info the coordinator is gathering, he or she will have a release of information for the audiologist signed at that time. Our office will then fax the release to the audiologist asking for the report so we have it prior to the assessment for service planning. The audiological information is then reviewed by the team prior to the assessment, and then in the event additional information is needed, the assessment team can contact the audiologist for what is supplemental and needed for the assessment date. So now it's time for the assessment for service planning, or the ASP. When a child that has been identified and hopefully has had their follow-up audiological comes into our office or we go into the home for their assessment appointment, I usually have seen the audiological reports and know what their hearing loss is. As is sometimes the case, we may not have heard back from the audiologist with a report, and we must rely on the family to provide us with the information as best they can. Most times, even if a family member did not understand all that was explained to them at the follow-up audiological appointment, they did understand if a permanent hearing loss was discussed. If their hearing test results show an inconclusive result, we suggest they don't wait and go back to their audiologist right away or seek a second opinion. We still encourage that family to enroll in EI, as they will still need help with alleviating fears through the process and understanding all of the information. So at the assessment, the team consists of 2 disciplines based on the needs of the child. So it might be an SLP, speech and language pathologist, and a PT if there are motor concerns. In our office, a service coordinator is always present and making note of parent concerns and child and family interest to help the family when writing the Individualized Family Service Plan, or IFSP, later in the appointment. Also, the assessment team may consist of only 1 discipline if they feel comfortable, and the service coordinator. The audiological report of the child's hearing loss may serve as a second discipline. We administer the Hawaii Early Learning Profile, or HELP, in our office, and we would proceed in our usual manner for our assessment. Once finished, assessment results are shared with the family with additional information provided on how the hearing loss may be affecting each of the developmental areas and the indicators. How do we share language and communication options with the family? During the development of the Individualized Family Service Plan, or IFSP, language and communication choice of the family is discussed. If the family has not decided yet, an unbiased description of communication options is given to parents. One is the Virginia Resource Guide for Families of Children who are Deaf and Hard of Hearing. This may have already been mailed to the family when they were diagnosed. This booklet was put together by the Partnership for People with Disabilities through VCU and the Center for Family Involvement. It contains not only a description of communication options for the family and child, but also includes information about newborn screening, hearing loss, listening devices, early intervention, and then school-age services. Another site for descriptions about communication options in a helpful reference chart is found at North Carolina's Beginnings, and the website is listed here. I encourage families to take home the information as well as research on their own what communication option best suits their family. Then we will also share additional pediatric audiology agencies if the family has requested. We will help the family with additional testing funding if needed, or to find another audiologist, and Part C funding is used as a last resort. So now it's time to write goals and outcomes with the family for their child for the next 6 months. In our office, that occurs with the service coordinator. At successforkidswithhearingloss.com, there is a wonderful resource for help in writing goals that capture what the family may be asking for their child. It's a helpful tool when parents aren't sure what they should be asking for. One example a parent might ask is, we want Sam to develop a basic vocabulary so he can express his wants during meals. On this chart, it gives information where a reference can be made in the goal that he is offered choices, or he labels objects with pictures, or that parents will use signs in natural routines, or use printed signs as some examples. Another goal a family might ask for is, we want Sam to learn to listen. Within that goal, a reference might be made to include that he reacts to his mom's voice by pausing or turning when she says his name, which would be very natural and within their daily routine. Once the family has made a choice as to the language and communication modality for their child, the service coordinator will then match a service provider to the family that can best support the choice for their child. This communication choice may have happened prior to the ASP, or it may occur after the family has had time to look over the resources and decide later. Another resource that is shared with families is the Family to Family Network of Virginia. This support for families is through the Center for Family Involvement, which is housed at the Partnership for People with Disabilities at VCU. In addition to providing support for families of all children with disabilities, it includes information for families that are starting on their journey with hearing loss. Resources are listed on hearing loss and communication, support groups, service options, and other information. At the heart of the Family to Family Network of Virginia are the 136 Family Educators. This group of parents specializes in helping families of deaf and hard of hearing children, and each family educator is also the parent of a child with hearing loss. A family is matched to a parent educator that most closely meets the unique needs, concerns, and location of that family. The family educator provides unbiased guidance to help families struggling with the diagnosis of their child's hearing loss and the frustration that comes with navigating the complex systems and services. Pictured here is Valerie Abbott, one of the family educators. She has a daughter that was diagnosed at 2 years of age with a hearing loss and was enrolled in early intervention until she transitioned to school system services. So let's talk about some communication options. American Sign Language. ASL is a visual language. Speech reading or listening skills are not needed to learn ASL fluently. It also uses hand shapes, facial expressions, and hand and body movements to convey concepts more easily. ASL is a language complete in itself. It is not written or spoken, but it is translated into spoken or written English. ASL has its own syntax and grammar and is a grammatically complex language. Parents and family members are committed to learning and using ASL consistently throughout their daily routines and activities. There are two variations of American Sign Language. One of the variations of ASL, but not to be confused with it, is Pidgin Signed English, or sometimes called Signed English. Pidgin is widely used by teachers of the deaf and hard of hearing. The vocabulary is drawn from ASL, but follows English word order. Words that do not carry meaning are dropped, such as is, am, or it, as are word endings, ing, ed, s's. This means the signer can easily speak while signing, since it is possible to keep pace with spoken English. Another variation of sign language is SEE, S-E-E, or Signing Exact English. Again, this is based upon signs drawn from ASL and expanded with words, prefixes, tenses, and endings to give a clear and complete visual presentation of English. It will also use initials of words or variations of a sign to differentiate it from another concept that uses the same sign. Using signed exact English requires more signing time than Pidgin or ASL. Another communication choice is bilingual, bimodal communication. Bimodal bilingual communication approach means the development of two languages in two different modalities. Bimodal being two different modes of communication, in this case signing and then spoken. Bilingual being two languages, ASL being its own language and then English. ASL and English are each developed, used, and equally valued. The goal of this approach is for each child to acquire linguistic proficiency and English in the written and spoken form. Spoken English is a component of this approach. Cued language is another visual mode of communication. This uses hand shapes and placements in combination with the mouth movements of speech to make the phonemes of a spoken language look different from each other. Literacy is actually the original and primary goal of cued speech by providing the appropriate phonemic language base for learning to read. There are 8 hand shapes that distinguish consonant phonemes. In addition, there are 4 locations near the mouth to distinguish vowel phonemes, and then a hand shape and a location together cue a syllable. Mouth movements of speech then combine with cues to make all the sounds of spoken language look different. The listening and spoken language approach to communication teaches a child language through listening. It follows the same trajectory as how a baby with normal hearing learns to talk. They learn by listening to the speech and spoken language of their parents, caregivers, and family members. Children with hearing loss can learn spoken language the same way as their hearing peers when they are identified early, have appropriate hearing devices, and are taught to listen through listening and spoken language techniques. This is considered a developmental approach, which follows typical child milestones by introducing skills at the ages and stages when language learning is at its most optimal level, birth to 3.5. There are key principles that are followed, including consistent and early use of hearing technologies, natural and sequential development, a focus on inclusion with family and hearing peers, and then also that early detection and diagnosis of the hearing loss. For all of the language modalities we just touched on, it is our hope in EI that when a child is identified early, enrolled in services by 6 months of age, and the family is able to fill their home with language in the chosen mode of communication as early as possible, that all children will be able to reach those language milestones as close to their hearing peers as possible.